Hi there, welcome to Body Language. I'm Edgar Champagne at CTV Beam. Welcome to the show that listens to your body. What is your body telling you? You could have an ache or some kind of a throbbing or something. Your body's trying to talk to you. What is it actually saying? Today we come to you with a very, very special guest and a personal friend of mine. Ladies and gentlemen, he comes to us with a Bachelor of Science degree in anesthesiology, a Doctorate of Medicine, University of Iowa College of Medicine, with fellowships. He's got an Alabama Sports Medicine Institute with Dr. James R. Andrews in Birmingham, Alabama, a hand surgery fellowship at the University of Virginia College of Medicine and Health and Science, Department of Orthopedic Surgery with Dr. Frank McHugh in Charlottesville, Virginia, and a spine fellowship at Baylor University College of Medicine, Department of Orthopedic Surgery and Surgery Section with Jesse Dixon, he's the director actually in Houston, Texas. Dr. Alexander, welcome to Body Talk.
Thank you very much.
Body Language.
Pleasure indeed, my friend.
Yeah,
absolutely.
Now, I've known you for a long time.
Yes, you have.
In fact, we went to school together.
Yes, we did.
I didn't wind up being a surgeon.
That's okay.
It's okay.
You did pretty good.
Yeah,
you did
thank
pretty
you,
well.
thank you. But listen, there's a lot of things going on right now with health, and people are conscious of that with not having insurance and everything.
Absolutely.
And people are breaking things, and so I thought, bones and orthopedics would be very important to discuss.
Of course, absolutely.
So what are the effects of obesity, since we see so many people out here? What are the effects of obesity have on with back joints and knee and back pain and what have you?
Edgar, that's a very good question because as an orthopedist, I dealt with issues surrounding complications of obesity for a while. What you have to look at, first of all, is obesity. What do we describe? How do we determine what obesity is? Mm-hmm. And basically, it's a reflection of the amount of excessive body fat that we're carrying. And so when we talk about having a BMI, which is what is the index that we use to determine what obesity is, we're looking at just how much body fat or excessive body fat we're carrying around, because it has a lot of biomechanical and physiologic consequences on the body. If you look at just the joints, if you're carrying around a lot of excessive weight, then what happens is that causes a tremendous amount of biomechanical loading on the joints. So your ankles, your knees, your hips become overloaded, and then subsequently your back. And so we start having some major problems with pain. So that's one of the main things that we have to be concerned about. If you look at it from a biomechanical standpoint, every pound that you carry around, you're generating 3 pounds of biomechanical loading every time you take a step. So if you weigh 150 pounds, every time you take a step, that's 450 pounds of loading that you place on that knee or that hip or your back with each step. That increases by 4 when you're walking upstairs. That increases by 7 or 8 if you're running. So think about it. You have someone who's weighing 200 pounds, who's weighing 200 pounds.
Yes, sir.
If that person is going upstairs, every time he or she goes up a stair, that's 800 pounds of loading that's placed on that joint. So it causes a tremendous amount of strain. It also leads to premature degeneration of the cartilage that lines the joints. So a lot of different things are involved with that.
Well, what's the best way to ensure that you can have a time schedule for exercise?
Well, I tell you, we're in such a mobile society right now. Mm-hmm. And everyone is working 25 hours a day in a 24-hour day. And so one of the biggest questions that I have, or one of the largest conundrums that I found with my patients when I was practicing, because by the way, I've been retired from clinical practice for about 5 years. But they would say, Dr. Alexander, I don't have time to exercise, because exercise is one of the most preventable methods for slowing down the adverse effects of obesity and the subsequent effects of osteoarthritis. So they said, well, how do I have time to exercise? I said, well, this is what you have to do. It's like anything else. You make time for yourself the same way you make time for your job. So we know that you're going to go into your job every day.
Yes.
because that's a responsibility that you have. So I'll ask my patient, what time do you get up in the morning? And she may say, I get up at 7:30 because I have to take care of the kids, I have to get them ready for lunch, I have to get them ready for school. I said, okay, if you get up at 7:30, this is what you need to do. Get up at 6:30. If you get up at 6:30, you have no one who's basically beating the drums, demanding of your time for 1 hour.
Right, right.
Just 1 hour. Mm-hmm. So for that 1 hour, you take it upon yourself to exercise. And when getting to exercising, one of the other questions that they ask is, well, how can I exercise if I'm having all this problem with my knee pain? If I'm having all these biomechanical stresses, it hurts when I try to walk, it hurts when I try. Well, there are a lot of different things that you can do to exercise that don't strain the joints as well biomechanically, such as bicycling, stationary bike, aquatic exercises, rowing. Mm-hmm. All these things can be done and can be just as effective. But the key is finding that time and being vigilant with taking that time in order to be able to mitigate, the effects of obesity and arthritis.
But now, again, I picked up a very, very good nugget there. You said that if a person goes upstairs, it's compounded by 4 times the pressure that we put on our joints.
Absolutely.
If we run, it's 8 times?
That's right. It's 7 to 8 times. That's exactly right.
And so if a person gets in their 30s and 40s, they've really abused, especially if you were, say for example, and not to pick on anybody, but if you were obese or overweight as a young person, like in your teens, mm-hmm. when you get to your 40s, that's an enormous amount of wear and tear on those cartilages, right?
Yes, it is. It is. It's a cumulative loading that you wind up having. And just by attrition and time and duration, it places a considerable amount of wear on the joints.
Is it, you know anything about baking, like biscuits and rolling dough? How the pizza guys do that?
Not very much.
But I mean, would it be comparable to them rolling out the dough? I mean, getting it flatter and flatter and flatter on that cartilage?
Yes. Now that is a good analogy, Edgar. Uh-huh. What you have to realize is that, let's just take the knee joint.
Okay.
The knee joint is made of the distal femur, so that's the lower part of the thigh bone, mm-hmm. and the top of your shin bone, your tibia, and your kneecap. Those are the bones that are involved in the knee joint. Each one of those bones have cartilage, which is sort of a buffering, a biomechanical buffer,
sure,
a decompressive loading device for the knee. Now, what happens is over time, if you continue to have excessive loading, then the cartilage becomes thinner.
More and more.
More and more, exactly. Mm-hmm. As the cartilage becomes thinner, then you start accelerating the biomechanical loading on the knee. And then you start losing the ability of the knee to have synovial fluid, which actually helps to lubricate the knee. And then once the cartilage is gone, you're going to wind up having bony osteophytes or bony spurs that develops in the knee. So it goes back to what you were saying before. As that dough is flattened or narrower, you wind up with direct bone-to-bone interface. Now you're getting a lot more friction between those two surfaces because the cartilage is not there.
Yeah.
And that causes pain.
All right, then, retired surgeon Dr. Emory Alexander is my special guest right now on Body Language. We're talking about the knee. We're going to come back and talk to the good doctor about knee replacement in just a little bit on Body Language. Thank you for joining us. We'll be right back on CTV Beam.
Marie, you have prediabetes.
Prediabetes? I don't have time to eat right or exercise. I'm a busy mom.
Oh, you're a busy mom.
Yeah.
This is great news. Busy moms never get prediabetes.
Wait, what?
Let me just... Yeah, this is all the people at risk for prediabetes, and way over here, busy moms. No?
Are you thinking about buying medicine online? A search for online pharmacies yields more than 20 million results. But which ones can you trust? Medicines bought from unlicensed online pharmacies can be dangerous. You may get a fake drug, your condition may get worse, or you may experience a bad reaction. Don't put your health at risk. To learn how to find an online pharmacy that's safe and legal, visit fda.gov/BeSafeRx. A message from the U.S. Food and Drug Administration.
Welcome back to Body Language, the show that asks the question, what is your body saying to you? You could have an ache, some kind of a headache, or it could be a joint pain or whatever. My special guest right now is retired surgeon, orthopedic surgeon, Dr. Emory Alexander. Dr. Alexander, we were just talking about the, I guess the knee and the, I guess the what is it called? The thing?
Cartilage?
Cartilage, yeah.
Yes.
Yeah.
Mm-hmm.
Now, some people get to the point where they really have to have surgery. Mm-hmm. And that's your job, is basically operating in knee surgery and what have you. What goes into knee replacement surgery? What happens with that? Talk about that for a moment.
Very good question, Edgar. One of the things that you said was my job, one of the things in my job is to do knee replacement surgery or to do surgery.
Yes, sir.
In actuality, the surgery, the knee replacement surgery, should be the last resort. And that's the thing that it's important to make sure that people understand. Now, let's just talk about knee replacement surgery in the context of arthritis, or as we just talked about. Sometimes patients, because of trauma, because of degenerative orthopedic changes, sometimes just because of disease processes, such as advanced rheumatoid arthritis or some of the other things, the cartilage is prematurely worn down, or is prematurely or irreparably damaged.
Sure.
And then what you have to do is to try to go back and replace the surface of the knee. When people talk about having a knee replacement, you're not really replacing the knee. You're replacing the articular surface of the knee. You're replacing that dough that we talked about earlier of the knee. Because when you're going in, what you're doing is you're removing several millimeters off of, again, the distal femur, removing the cartilage. You're removing the cartilage from behind the kneecap. You're removing the cartilage from the surface of the tibia. And you're maintaining all of the capsule, all of the ligaments, the entire balancing complex for the knee, the muscles around the knee, all those things are preserved. So all you're really doing is restoring the articular surface. And I think that's important for people to understand, so there's not a misnomer, because people think about, total knee replacement, oh, they're going to replace my knee. We're not doing that. We're just replacing the surface. Now, once you determine that a person needs to have a knee replacement, and again, there are so many different types of knee replacements that can be done. Sometimes if the cartilage is just worn on one side, you can do sort of what we call a hemiarthroplasty, or we can actually replace half of the cartilage if the other half is actually okay. So it's not an all or none proposition all the time. You follow me?
Yeah.
And so one of the things that we want to make sure of when we have patients coming in for knee replacement surgery is determining that what is the best time to have that done. And patients will come to me and say, Dr. Alexander, when should I have this done? I tell them, surgery is a personal decision. Pain is a very personal experience. The indications for knee replacement surgery is when you have such debilitating, compromising pain that it impedes your ability just to do normal daily activities.
To have just a comfortable daily activity.
Just to have a comfortable daily life. And when you get to the point where you can't do that, in the face of advanced degenerative changes that are demonstrated by imaging, and you've also tried physical therapy, you've tried non-steroidal anti-inflammatory medications, you've tried all the different non-surgical modalities that should be part of the treatment algorithm, and if those things don't work, then the time to have the knee replacement surgery becomes an appropriate part of the algorithm.
When You were talking about doing half
Yes.
of the knee and the cartilage replacement, and you call it a
Hemiarthroplasty, yes.
Hemiarthroplasty, okay. When you all are in there, and this is just my curiosity, I want to know this.
Of course.
When you all are inside that person's knee, there are veins and arteries and stuff going on and everything. You say that remains in place. You never bother that.
Absolutely.
And you're
Absolutely.
in there cutting around and stuff.
Yes, because what happens is anatomy, and this is one of the beautiful things about the way we are created. Mm-hmm. There's perfection in consistency with the way we're created. So, when we're in medical school, we learn basically where the arteries are. We learn where the nerves are. We learn where the muscles are. We know the configuration of the anatomy. And it's pretty much, but for the most part, a constant. So that allows us, when we're developing our surgical techniques, to be able to know exactly what planes and which directions and which vectors we need to go, which allows us to remain safe for our patients.
This is good. This is another layman's question. With all of our brilliance, we have not created a artificial cartilage that we can put in the knee, or have we?
That's true. We have not. We have not. But what is interesting now, and that's a great point that you bring up, Edgar. We have now this evolving science of regenerative medicine. Mm-hmm. You may have heard the term.
Sure.
So now we have this entire new translational science that is being done, which allows us to take cells, which can be changed, and these are commonly, you may hear the term stem cells. So we could take these stem cells, and these cells are basically sort of what we call pluripotential cells. They can actually convert or change into any type or different types of cells.
Right.
So eventually, that cell now can be engineered to where it can actually now become cartilage cells, and it can or it become liver cells, or it can become lung cells. And so now you're able to regenerate tissues and organs which had been previously irreparably damaged. So the wonderful thing about this evolving science is that hopefully in the near future, using regenerative techniques, we'll be able to come up with new ways to regenerate cartilage. But to answer your question, at this point, we don't have the great silver bullet for that. Yeah. But it's coming. It's continues to evolve.
Yeah. Well, you can see that I have a very, very special guest today, a very knowledgeable person, retired orthopedic surgeon, Dr. Emory Alexander. And we're going to record, matter of fact, Dr. Alexander is going to be with us for 2 shows. We're going to record 2 shows today talking about things that you really would be fascinated how deep this gentleman really is. You're on Body Language at CTV Beam, Dr. Alexander. With all the computers out there,
yes,
and people are texting,
yes,
and what have you. We started out with typewriters and word processors and computers. Mm-hmm. People are at their desks and cubicles and everything. There's such a thing as carpal tunnel syndrome. I'd like for you to talk about that in just a little bit when we come back, okay?
Absolutely.
All right?
Absolutely.
We'll be right back with Dr. Alexander on CTV Beam. This is Body Language. Don't go away.
Body language. Without saying a word, it can tell you so much. Like someone is having a stroke. Know the sudden signs. Learn fast. F, face drooping. A, arm weakness. S, speech difficulty. T, time. Time to call 911 immediately. The sooner they get to the hospital, the sooner they'll get treatment. And that can make a remarkable difference in their recovery. Learn the body language, the sudden signs, and spot a stroke fast.
Hi there, Edgar Champagne with you, and we are Body Language, the show that asks the question, what is your body actually telling you? My special guest is retired orthopedic surgeon, Dr. Emory Alexander. Before we went to a commercial, we were getting ready to talk about carpal tunnel syndrome.
Sure.
So many people work on computers, and there's a new phenomenon with gamers.
That's
people
exactly
are just
right.
addicted to these computers, and they're just playing.
Yes.
And that's repetitive motion.
That's right.
And it's causing ailments in our wrists and our fingers and everything else. Talk about that for a moment and how surgeons are able to help people with that, sir.
You know, and I'm glad that you mentioned that, Edgar, because today we're seeing this phenomenon of esports, in which there's a lot of gaming, and I mean, it's amazing. I'm seeing a lot of this on ESPN.
Yeah,
I mean, it's phenomenal. But with that comes the consequences of having problems with your hands, with your wrist. And there's a condition called carpal tunnel syndrome, which is a very common condition that we treat in orthopedic surgery. And so I'd like to talk with you about that in the context of it. If you look at the carpal tunnel, first of all, when you say, well, what is the carpal tunnel? Mm-hmm. The carpal tunnel is actually a pathway in the wrist. The floor of the carpal tunnel is actually created by the bones in the wrist. There are about 3 bones in the wrist and along the side that actually makes up the floor of the carpal tunnel. The roof of the carpal tunnel is actually made by this transverse carpal ligament, which is part of what's called the flexor retinaculum. It's just a fancy name for a band that runs across the front of the top of the wrist.
Yes, sir.
So now you have the band, and through that tunnel, you have 8 different tendons that are responsible for moving the fingers, moving the 4 fingers. You have the profundus tendons, which actually moves parts of the fingers, and then you have what's called the superficialis tendons. But the bottom line is you have 8 tendons that runs through the tunnel. Also, running through that tunnel is a nerve called the median nerve. Now, the median nerve is the nerve that is responsible for helping to move these fingers, but it also is responsible for sensation in the thumb, the index finger, the ring finger, and the radial half of the ring finger. So those 3.5 digits are the digits that are innervated by the median nerve. If you have something happening that causes compression of that nerve as it comes through the tunnel, and again, one of the most common problems that we see is repetitive motion. If you're doing a lot of work on a keyboard, if you're playing gaming all day, then what you get is what we call APMs, or actions per minute. There are different actionable events that are going on per minute in your hand. And it can actually reach a certain crucial rate whereby the ligament becomes thicker, causes compression of the median nerve, and you have resultant pain that can actually start off in the palm of the hand. You can get pain, numbness, and tingling going down your thumb and these 2.5 fingers. You can wind up having weakness to hand grip. You can actually get to the point where it can be so severe that it could actually cause you to have problems with normal prehensile dexterity, using or being able to manipulate fine objects. A lot of times this pain can be very severe. It can be severe enough to where it radiates all the way up to your neck or to your shoulder. And that's one of the things that you have to be concerned about too, because those types of symptoms are very similar to other types of problems that we have in the neck or in the spine. So we have to be very careful to determine exactly what those symptoms are and the etiology of them.
Using the analogy you just gave us, the median nerve, mm-hmm. and with repetitive actions,
yes.
Is that the pressure comes down, is that like a form of a callus, or it's just actual pressure bearing down on that nerve to make it happen?
No, it's not callus. It's actually just pressure bearing down on the nerve. There could be just primarily inflammatory changes. It could be just swelling. It could be accumulation of fluid, or it could be anything mm-hmm. that actually causes compression or causes a lessening of the amount of space as the nerve travels through the tunnel.
Okay. Well, As you were talking about that nerve, it goes somewhere. What is the meaning of cervical stenosis then? Because that nerve is going somewhere. And
Okay. You know, it's interesting. One of the problems that we run into with cervical stenosis, and let's just talk about what that is.
Yes, sir.
And how it may even simulate symptoms of carpal tunnel. Cervical stenosis means narrowing stenosis of the cervical part of the spinal column. The cervical part of the spinal column is actually in the neck. And so you have to realize that at that level of the spinal column, you have signals that actually comes through the spinal cord, ascending and goes to the brain. You also, at the same time, have signals coming from the brain, coming through the cervical segment of the spinal canal, and those signals goes down to the spinal cord, or they may actually go to the nerves that actually comes off your arm. Now, if the spinal cord is compressed, if there's less room as the nerves are coming off of the neck, then it could cause what we call myelopathy, which is weakness. You have difficulty with standing. You have imbalance problems, coordination problems, inability to do normal things with your hands or your arms. You can actually have radiculopathy symptoms, which are pains that actually generate down your arm and can cause pain, numbness, weakness, tingling in your hands. Very similar in character to carpal tunnel.
Wow, that's incredible. Well, what about lumbar stenosis and treatment for that?
Well, lumbar stenosis is very similar to cervical stenosis, if you will, except that the lumbar part of the spine is actually the lower back. When we talk about the lower back, we talk about the lumbar area. Remember, you also have the spinal cord that's running from the neck all the way down to the tailbone of the sacrum. It actually stops short of there, and then you have the nerves actually coming off the spinal cord and going down to the corresponding muscles and structures in your legs. So with lumbar stenosis, the same thing happens. There is pinching, there's narrowing of the spinal cord, of the spinal canal, and so you get pressure on the nerves as they're coming off of the spinal column, and that causes the same thing: muscle imbalance, weakness, pain, numbness, tingling in the lower legs. As the nerves come off the lumbar spine, as we talked about before, God made this roadmap. That's a pretty good constant. So we know that depending on which level a nerve is coming off, or depending on the patient's symptoms, we have some idea of which nerve is being aggravated. You follow me?
Sure.
And so the same thing with cervical stenosis. If we know that the pain is actually coming down and it's affecting weakness in your biceps, we know just the way that we've been made that that nerve is a specific nerve. We know that if the nerve is affecting the triceps, if there's triceps weakness or wasting of the muscles, we know that there's a specific nerve that's actually affecting the triceps.
All right, thank you very much for joining us on Body Language. Edgar Champagne with my special guest, Dr. Emory Alexander, retired orthopedic surgeon. He's going to stay with us for another extensive information on the bones and some of the research that his company has done called Onyx. That's next week on Body Language. Stay with us on CTV Beam.